right, it's a pleasure to be here. We're at the 2018 Dysautonomia International Conference in Nashville. I want to thank Lauren Stiles, the director, for inviting me. And I want to start by telling you that I don't consider myself an expert in dysautonomia or POTS. It has become clear to me and to the faculty at Stanford that sometimes there is a capacity or the potential for misdiagnosing someone who has a spinal fluid leak as having something in the POTS family. And so I'm going to talk to you about spinal fluid leaks because spinal fluid leaks are a problem that can be fixed. People go from being chronically disabled to feeling better, and it's really important if you have a spinal fluid leak or you know someone who has a spinal fluid leak that they get turned on to that diagnosis and appropriately treated. You will see throughout my talk today QR codes like this. They're meant to link you to resources to be helpful to you. This QR code links to a Google Drive folder that I keep for patients who are wanting to know more about spinal fluid leaks. It contains some review articles on spinal fluid leaks. It contains something called a 48-hour flat test instructions that we use to help people determine what symptoms they have and whether they in fact get better with prolonged recumbency or laying flat for a long time. It contains a link to a document of people around the English-speaking world who treat spinal fluid leaks at Stanford and other places. That'll be useful to some of you watching today or watching later at home on YouTube. I want to disclose I have no financial disclosures. This work is supported by a generous gift from the family of someone who we identified as a leak and fixed. The Considine CSF Leaks Fund, which has really kick-started our efforts at Stanford. I want to say thank you to them. So what is spinal fluid, or CSF, cerebrospinal fluid? It's a fluid that's made in the brain. Inside the brain itself, there are hollow spaces called ventricles that make fluid. The fluid comes down through the brain and ultimately escapes out here. And from here, it both circulates around the brain and circulates a long way down the spine, surrounding the spinal cord, which is the dark part here. And that spinal fluid serves a function of providing buoyancy to the brain. Your brain is made mostly of fat. Fat's less dense than water. The spinal fluid is primarily the density about of water. And so it reduces the weight of your brain from about a kilogram, about 2 pounds, down to 45 grams. So it reduces it something like 96%, so that your brain is walking around in its own private swimming pool. And the floor of that swimming pool is the spine. And so like any vessel containing fluid, this vessel can develop a leak. Usually, if it develops a leak, it's not in the skull base. It's almost always somewhere along the spine. The spinal fluid is contained by a watertight membrane made of connective tissue called dura. And the dura can be genetically weak in people who have hereditary disorders of connective tissue. And in such people, that dura can spontaneously tear or rupture. In other words, the people who have hereditary disorders of connective tissue who are walking around this conference here are exactly the kind of people who are prone to developing spontaneous CSF leaks. The dura can also be torn by seemingly minor trauma and can be punctured by sharp edges, whether those edges occur naturally as in bone spurs or from doctors with well-meaning intentions, yielding needles or scalpels or screws in spine surgery. So what are the symptoms of a spinal fluid leak? The cardinal, easiest to recognize symptom is a headache. Now, this is where you have problems as a patient. So if a doctor causes a spinal fluid leak by sticking a needle into the spinal fluid, that new leak that's down low in the back pretty reliably causes a specific kind of headache called an orthostatic headache, in which when you lie down and get flat, you feel better pretty quickly. When you, in fact, get upright, you feel worse pretty quickly. However, if you have a chronic leak, that easy distinguishment starts to go away, and you have to be flat for longer to start to feel better. And in fact, in people with spinal fluid leaks, especially chronic and spontaneous spinal fluid leaks, often the most common headache is not one that feels better right away when you lie flat, but actually is a second half of the day headache. You wake up every morning feeling better because you've been flat for 8 hours. Then you get out of bed, you start moving around, the headache starts to kick in. Maybe it kicks in within 10 minutes, maybe it kicks in within 2 hours, depending on the speed of the leak and your capacity for sustaining your spinal fluid volume. I will tell you, it is well documented that some people with spinal fluid leaks have no headache. It is well documented that some people with spinal fluid leaks have exertional headaches. And then there's a whole group of people whose head pain is such that they can't really tell that they feel better when they're flat until you make them actually go spend a lot of time flat. And flat means really flat. For people who have spinal fluid leaks, just having your head up on a pillow can sometimes be enough to provoke symptoms. So if you're going to test if, in fact, being recumbent or being flat makes your head pain better, you've got to be flat without a pillow. The other symptoms of a spinal fluid leak, something like 80% will have tinnitus. A great majority will have some degree of nausea and vomiting. Almost everyone has neck pain. Profound fatigue is a common symptom, and often symptoms that I kind of group together as neurologic weirdness, unexplained cognitive difficulties, difficulties with memory, concentration. I've had patients tell me that they got lost driving somewhere that they've been to 50 or 100 times, their daughter's ballet theater. So you can get all kinds of brain dysfunction. The thought is the tinnitus occurs because the fluid in the inner ear actually communicates with the spinal fluid. And so people wind up with abnormalities of hearing. They can report muffled hearing, a sense that they're hearing things from in a bubble or underwater. And similarly, because the inner ear fluid is affected, often vertigo, dizziness. So what we see is that the spinal CSF leaks have a troubling similarity to POTS. All right? People feel worse when they're upright. Headache is very prominent. The studies that are out there looking at patients with POTS, or postural orthostatic tachycardia syndrome, suggest that 65% have headaches. Nausea and vomiting, pretty common in both syndromes, as is lightheadedness, dizziness, brain fog, fatigue. And what should be most troubling to people out there is that hereditary disorders of connective tissue appear to be a risk factor for the only two known conditions that are characterized by headaches feeling worse when you're upright and these protean neurologic symptoms. So you have two clinical syndromes that symptomatically are very similar, and they both happen to be things that you're predisposed to if your connective tissue is not strong enough. One of them is totally understood and fixable, spinal fluid leaks, and specifically spinal CSF leaks. One of them is mysterious, and a lot of treatment involves, as Lisa Sanders put it in her New York Times piece, learning to cope. And so what's really important to me is making sure that if some of the people who think they have this really have this, we got to make sure that we fix the people that we can, and the people that we can't, maybe they don't have a leak. So let's examine a published case and see how a concrete diagnosis was arrived at in actual practice. So this case was published in February of 2015 by Lisa Sanders. She's the doctor that the Dr. House was based on. She's an internist, I understand, at Yale. I've never met her. And she wrote this piece for the Well section of the New York Times. And this is part of what actually led to the chain of events that leads me here today to you. She writes about a case of a 21-year-old woman in Boston who was home on college break while a junior at college, who presented to one of the Harvard hospitals with dizziness upon standing and passing out. That was in 2001. Before that time, the piece notes that her history was remarkable for scoliosis, pain in her temporomandibular joints, widespread body pain, and a grade 2 L5-S1 spondylolisthesis. What's spondylolisthesis? It's when basically part of the spinal column shifts forward or backward on top of another part of the spinal column. So if you follow the line up here, you should find this next vertebral body right on top of this, but it's actually slipped forward. And actually, this constellation of symptoms in a 21-year-old who has not had significant trauma bespeak the stigmata of a hereditary disorder of connective tissue. Unless she was dropped out of a third-story window, they should not have, an otherwise healthy 21-year-old woman shouldn't have a grade 2 spondylolisthesis and a history of temporomandibular joint pain and a history of scoliosis. So she's got the stigmata that make her right for having something like a spinal fluid leak. We know that, and this is the citations for genetic disorders of connective tissue being a risk factor for a spinal fluid leak, but why are they a risk factor? Well, one reason is if you look at the bag of spinal fluid, which is here, this is an image from a CT myelogram in which contrast has been injected into the spinal fluid. What you see is as you come up, where the nerve roots are here, you have these little saccular aneurysm-type structures that are full of contrast. So spinal fluid is getting up into this, and if these things get large enough and thin enough, just like an aneurysm in a blood vessel, they can pop. And when they pop, suddenly you get the sudden onset of all of those symptoms that we just talked about. And these kinds of aneurysms are thought, well, these kinds of dilations in the thecal sac are neuroradiologically termed perineural cysts. But when you think of a cyst, that doesn't explain what these structures actually are. These are essentially aneurysms of the thecal sac. And they develop from an area of weakness in the dural sac. The pressure of the spinal fluid causes that to expand, get bigger, get thinner, and ultimately they can pop. So that's one way in which a hereditary disorder of connective tissue can predispose you to a leak. Another one is what's illustrated here. So here's a CT myelogram that looks pretty normal on the left. Here's a myelogram from a patient who has degenerative changes essentially at every level that's visible here. And you'll notice that not only are the disc spaces kind of completely eroded, but we have the formation of these bone spurs at multiple levels, and the bone spurs have little calcifications on them pushing into the front surface of the bag of fluid. You can get a little illustration of that here. So the hereditary disorder of connective tissue plays itself out here, both in the degenerative changes that lead to these osteophytes or bone spurs pushing into the front of the bag, and the bag itself being weaker. So back to our case of Dizzy in Boston, she has that history and the stigmata of a hereditary disorder of connective tissue, and then in May of 2000, she undergoes a surgery. What kind of surgery? She undergoes a surgery to address her L5-S1 spondylolisthesis. These are not her images. These are images of a surgery that's been done to correct a spondylolisthesis. And what you see is screws going in, doing what's called a lumbar fusion. And the reason that this is concerning is because we know that spine surgery is a known precipitant of CSF leaks. There's even publications that leaks can occur remotely long after spine surgery. And one way that may occur, you'll notice if you look again at this image, if we take a cut across this way and look at that with a CT scan, it looks like this. Here's the back of the spine is here, the front of the spine is here, and these are the screws going in. There's one screw, there's another screw, and this is the bag of fluid with spinal fluid in it. And if this screw is just a 0.5 millimeter too medial here, too much toward the midline, it's going to tag the end of that bag of fluid on either side. And even if they don't, you can rely that there's going to be some scar tissue here, and that scar tissue may or may not be adherent to the dura and provide an opportunity later for the dura to be torn at that location. But you can see how easy it would be if the screw wasn't placed exactly perfectly for it to get into that bag of fluid. So she had this surgery, but her symptoms didn't start then. She then undergoes, the story that's published in the New York Times make it clear she had some kind of complication for which she needed a second surgery. They thought it was an infection. But then in September of 2001, she has a whiplash accident. And it's clear from the story in the New York Times that the whiplash accident is followed by, quote, intractable headaches, much worse, especially when the patient stood up. The definition of an orthostatic headache, the classic kind of headache seen with a spinal fluid leak. And then just a few days prior to her admission to the hospital, the story reports that she had another minor motor vehicle accident, which was followed 2 days later by not feeling well, 3 days later feeling more out of it, disoriented, vertigo, mild headache, frontal dull with shooting from the neck. Now, this is a paper that's published after that, okay? So we can't hold the doctors who saw her in 2001 as being responsible for being knowledgeable of this paper. This paper's published much later, okay? And in this paper, they talk about 66 patients with whiplash-associated disorder. What's whiplash-associated disorder? It's head and neck pain after a motor vehicle accident, also associated with things like ringing in the ears, difficulty with memory, difficulty with fatigue. And they looked at all 66 patients with whiplash-associated disorder with something called a radionuclide cisternogram, a study in which radioactive material is injected into the spinal fluid, and then you look to see where it might leak out. Of the 66 patients, roughly half, 36, were found to be leaking, and all were patched with blood patches, which is the defined treatment for a spinal fluid leak, where you inject blood or glue into the space outside, not into, outside the bag of fluid to kind of form a clot or a seal of the leak that then allows the normal cells of the bag to grow across and form scar tissue and seal it permanently. And what you see here is first of all, these people weren't diagnosed until an average of 3 years after their accident. Before their accident, they were basically all working full-time. After the accident, but before their blood patch, they're basically all disabled. And after blood patch treatment, roughly half of them are back at work full-time. The other part is going back to work part-time, suggesting that, in fact, whiplash, for some people, is a significant creator of spinal CSF leaks. So our patient in Boston, the dizzy patient, also complaining of neck pain, classic symptom for a leak, nauseated, we talked about that, difficulty with memory and concentration, and noticed that the dizziness was only present when standing and resolved upon lying down. So shortly after this second motor vehicle accident, comes into the hospital, and they arrive at a diagnosis. And the diagnosis they arrive at is based on this. They note that the head CT is normal. Turns out head CTs are virtually always normal when you have a spinal CSF leak, so we shouldn't weigh that too much. But they noted that her heart rate goes from 74 when lying down to 130 when standing up. And her blood pressure does not drop, but rather actually goes up. And they see this as a telltale sign of autonomic instability or dysautonomia. They perform a tilt table test, which is abnormal, and they arrive at the diagnosis of POTS. And in the extent that POTS is postural orthostatic tachycardia, by definition, she has that, right? Her heart rate goes up when she stands up. She has postural orthostatic tachycardia. That doesn't really tell me, though, if she has a leak or doesn't have a leak. But nonetheless, her workup stops. She gets diagnosed with POTS. And this is the first time I'm confronted with what I think is a good story for a spinal fluid leak for the reasons I've just gone through with you, and learned that, in fact, it's not a leak. So I will tell you that while this was going on, and the years preceding this, in February of 2013, my daughter was recurrently hospitalized for headaches. And it took us a long time, frankly, to realize that there were headaches because she wouldn't talk when it was going on. And it took us a long time to realize that her symptoms were in fact better when she was flat, and they were worse when she was upright, and to connect those with the 6 lumbar punctures she'd had treating her prior to that point, and realizing that she might have a spinal fluid leak. and then in fact treating my daughter. And it was through that process that I had started doing all of this reading about spinal fluid leaks. And so when I read this case in the New York Times, I wrote in my little thing saying I thought it was a spinal fluid leak, to find out the next day that in fact the right answer was POTS. So it was at this point that I thought, well, one of two things is true. Either this person really doesn't have a spinal fluid leak or they do, but either way, the story is really good for a spinal fluid leak, and maybe there's a potential for people who have spinal fluid leaks to be misdiagnosed with POTS, which caused me, to reach out to the POTS clinics at Stanford and start talking to them about patients who had good stories for leaks. And maybe they should send us some people if they had Ehlers-Danlos, they had some kind of trauma, and then they had headache as an orthostatic headache as a major part of their presentation. And before long, they started sending some people, at first a trickle, and some of those people got better after being patched, and so then that trickle turned into more of a trickle, and more people got better. And so I think it's clear that some people can have a story that sounds pretty good for one of these things and really have the other. So let's talk about how one might try to go about distinguishing one from the other and what the pitfalls are. So this is one of the things that always makes me a little sad. In the New York Times, what they talk about, this patient Dizzy in Boston, after the diagnosis, is that she was really learning how to cope, which is sometimes the best we can do in medicine, but sometimes we can do more. So things we should note. The patient was seen, and as you read the notes, as a doctor from Stanford reading the notes, it's clear to me that this patient was seen by thorough, caring, sophisticated physicians. The notes suggest that the stigmata of outstanding attentive physicians were there. She was seen at Beth Israel Deaconess, which is more sophisticated than 99% of all medical centers out there. They appropriately consulted experts and neurologists. And interestingly, they discussed the fact that some of her symptoms matched symptoms seen with disorders of elevated CSF pressure. So they were thinking a little bit about CSF pressure. However, they never discussed the possibility that she might have a leak. But again, to be fair to them, the paper I just showed you about whiplash and leaks hadn't been published yet. The papers talking about hereditary disorders and CSF leaks hadn't been published yet. MRI, the main MRI finding in CSF leaks of pachymeningeal enhancement had only been published 3 years before. So they were working at disadvantages that later historical people coming later, looking back, need to appreciate. But they didn't measure a CSF, in part because of the surgery that had been done at that level of the spine. They cited that it would make it technically difficult to look at the CSF, so they never measured CSF pressure. They never looked at the total protein in the CSF. They never measured her prolactin. So doesn't the abnormal tilt table test mean that POTS is the cause? POTS is a diagnosis. It is a description of what she's experiencing. She does have orthostatic tachycardia, but does that rule out a CSF leak? Well, what we really want to know about the study of a tilt table test is how good is a tilt table test at distinguishing between dysautonomia and CSF leaks? All right, so let's look at what's been studied about that. So I searched this week to update my knowledge. And I can tell you, as of June 2018, a search of PubMed, which is the database basically containing all medical publications, shows exactly 0 publications looking at, if you search under tilt table test and intracranial hypotension, which is what you look at for CSF leaks, or if you search under hereditary and sensory autonomic neuropathies and intracranial hypotension, you find nothing. There are no studies that have looked at people with confirmed CSF leaks and given them a tilt table test to see what happens. How many people with CSF leaks actually have tachycardia or orthostatic tachycardia? Nobody knows. All right, this is similar. As of June 2018, no papers have looked at the presence or absence of orthostatic tachycardia and CSF leaks. you will find one paper by Dr. Mokri, who first described the MRI findings of a CSF leak, in which there were 4 patients he looked at who he noted had classic symptoms of a leak, but they couldn't find a leak with their imaging, and all 4 of the patients had tachycardia. Of note, 3 of the cases had no spine MRI, 2 of the cases had no CT myelogram, none had a test that we do these days called a digital subtraction myelogram, and 2 of the 4 had documented temporary benefit from epidural blood patching. But because they couldn't find the leak with the imaging that they did do, recognizing they didn't do the imaging we would have done today, they didn't find a leak, so they said that, they all have, and they were all noted to have orthostatic tachycardia, so they were diagnosed with POTS and not a CSF leak, and that's where their diagnosis and treatment ended. That's it. That's the state of the world's literature on trying to distinguish these 2 things today. So did she have a POTS or did she have a CSF leak? I don't know. Can clinical symptoms distinguish between POTS and a CSF leak? I will tell you this, tinnitus, ringing in the ears, is very common with CSF leaks. That's well documented. When you search under POTS and tinnitus, there are no publications. Nobody's documented that POTS causes tinnitus. Nobody's documented that dysautonomia causes tinnitus. On the other hand, maybe tachycardia should be salient, so POTS should be diagnosed. But I've already told you, nobody's looked to see exactly how often tachycardia is there with CSF leaks. This is what I was just telling you about how there's really nothing about tinnitus. So the question then becomes, if you're interested in being evaluated for a CSF leak, let's say you have stigmata of a hereditary disorder of connective tissue, you're abnormally tall, you're abnormally short, you have joint hypermobility, you have stretchy skin, abnormal scars, a history of joint dislocation, a pectus excavatum, flat feet, vaginal prolapse, all kinds of things that can show that your connective tissue is not right, and you had a trauma that could maybe have done it, or you had a needle in the back, or you had spine surgery, and you want to know, do you have a spinal fluid leak? Well, I got to tell you, the emails that I get from across the country often come down to a few sticking points. One of the first sticking points is, my doctor won't assess me for a CSF leak because he says it's so rare I couldn't have that. All right, so how rare is it? This is a paper from Wouter Schievenk at Cedars-Sinai, a luminary in the field of CSF leaks, where they looked at people, they looked back at records of people presenting to the ER at Cedars-Sinai over the course of about 3 years. And they went back and looked at the actual neuroimaging to identify how many people walked into the ER that had imaging evidence of a CSF leak. And they counted those up. They found 11 over the space of that 3 years. They then compared it to a diagnosis that they knew the incidence of, this thing called a subarachnoid hemorrhage, where a little aneurysm in a blood vessel in the brain pops. We know that the incidence of subarachnoid hemorrhage is about 10 per 100,000, and in the same time period that they counted 11 CSF leaks, they counted 21 subarachnoid hemorrhages. So they estimate that the actual incidence of CSF leak is about 5 per 100,000. So now you can tell, if you get stuck talking to your doctor and them telling you that a CSF leak is so rare, you can tell them the incidence is 5 per 100,000, and that compares to the following things. Esophageal cancer is less common than that, but most doctors will have seen a few cases of esophageal cancer. The incidence of that's only 4.2 per 100,000. The incidence of suicide is not that much higher than the incidence of chronic spinal fluid leak. It's about 13.4 per 100,000. So, we've all had family or family friends who've had things like this, something that's on this order of magnitude is not that uncommon. If you say to the average ER doc, you should be diagnosing 1 CSF leak for every 2 subarachnoid hemorrhages that come in here, you're going to get a blank stare because they never make that diagnosis. And in fact, in the study that they did where they found those 11 cases, 0 of them was diagnosed correctly in the ER. So these things are common, and the most common thing is for them to not be diagnosed correctly. help your MD learn why you might be at elevated risk. So the next sticking point I get is you don't have the kind of thing that would cause you to have a leak. So letting your doctor know, and here's the citations for headaches starting after spine surgery. Here's the citations for headaches starting after whiplash injury, and the QR code that I told you at the beginning, in fact, will take you to a folder that has these papers, so you can print out these papers and bring them to your doctor and say, look, here's the evidence that this is common, here's the evidence it's linked to this precipitating factor, would you take a look at it and be willing to talk about this with me, right? And that's why you see here on the title, I'm talking about helping your MD, because, people think a lot of different things about doctors, but when I went to med school, my classmates were all spending enormous amounts of time and effort trying to learn how to help people. And they went to med school, not law school or business school, because they really, really wanted to help people. And there are a lot of people out there talking about crazy things. And when you come in talking about something they're unfamiliar with, they may think at first that it's crazy, and you have to help them learn more about it. So how else can we help your MD identify precipitating factors? So the other sticking point, I've had emails from people talking to me about how their symptoms started with a lumbar puncture, either an epidural where they put the needle a little too far and got into the dura, but then they were told that they couldn't have a chronic leak after that, or the chronic leak couldn't exist after they'd have one blood patch. This paper was published by Pam Flood, one of my colleagues at Stanford. Unintentional dural puncture with a TUI needle increases the risk of chronic headaches. So what did she do? She did a case control study where she looked at 40 patients who had known dural punctures when they had their epidural put in for labor and delivery, for having their baby. And she compared them to 40 patients who had the same kind of epidural but didn't have a known dural puncture, okay? And what she did that was so unique is she contacted these people 12 to 24 months later. Now, I want to point out, all of these people had the known problem. Their leak, and the inciting trauma to cause the leak was identified at the time, and they were all treated with what we understand to be best practice, okay? Here's the incidence of headaches as determined at 12 to 24 months. Among the control patients, only a 5% incidence of new chronic headache. Among the patients who'd had a dural puncture, when contacted a year to 2 years later, 28%, almost a third, reported new ongoing chronic headaches. Well, when somebody has a dural puncture, that can be managed one of two ways when we recognize it. We can treat it conservatively by having them lay flat for a day or two, giving them fluids and tracking them and see if they get better and seal on their own. And so some of those people are treated conservatively. If you were treated conservatively for your known dural puncture, the incidence of chronic headache a year to 2 years later is 40%. All right, we're getting up to close to half. If in fact you got a single blood patch, the likelihood of having new chronic headaches after your known dural puncture falls by half, but it's still 4 times higher than the background rate of 5%. All right? So it's clear that what we do often as doctors with impunity in terms of putting a needle in people's spinal fluid and their dura sometimes leads to prolonged problems that we're not very educated about, but there's evidence really happened. This is recently confirmed by a larger study of 308 unintentional dural punctures, which found almost the same. So here's the controls, and here's the data from the 308 unintentional dural punctures. When we look at new headache and chronic headache, 35% of the people who had known dural punctures compared to 2.1% of controls. Pretty similar to Dr. Flood's data. Also, very high incidence of chronic back pain in the people who had dural punctures, which was another finding from Dr. Flood's study as well. It seems that spinal fluid leaking out of the thecal sac is in fact irritating. And so if you have leaking fluid, you're going to have a much higher incidence of chronic back pain as well. So This is Caitlin. She was seen at Stanford at age 21 or so for a hip arthroscopy. Why at 21 she needed a hip arthroscopy? The most likely inference is maybe her connective tissue is not so good. She was seen, there was no spinal or epidural done, and in the recovery room she woke up with extreme pain. The pain service at Stanford, trying to help her with her pain, offered her an epidural for pain relief, and she accepted. They tried to put it in with her lying on her side in the recovery room, and they accidentally put the needle into her spinal fluid. This happens sometimes with epidurals, no big deal, in the sense that we know it's a complication, and when you try to put in an epidural and you're careful, sometimes this just happens. She was seen the next day by the pain service, and they reviewed the fact that she'd had a dural puncture, offered her a blood patch. She remembered the discomfort from the epidural the night before and declined. They told her, if your symptoms persist, let us know. We'll come by and do a blood patch. Pain service never heard from her. She never heard again from the pain service, and out she went into the world, where she lived with a pretty disabling headache and other symptoms, nausea that I talked about, until she wandered into the pain clinic 18 months later. And fortunately, the doc in the pain clinic put together, oh, this all started with your hip surgery? Okay, let's look at the records from that. Oh, you had a known dural puncture? And so she took a blood patch, and it took a second blood patch, and after the second blood patch, she was basically fixed. You also want to help your MD identify that bone spurs can cause spinal fluid leaks. You can see here, this patient's had a fusion in his neck. This is the back of the neck. Here's the front of the neck. This is the base of the jaw. The spinal fluid is the white stuff here, and the spinal cord is the dark thing here. And this, which is blown up here on the right, is a disc that has herniated and then calcified, pushing up against the spinal fluid, the dura. This is what it looks like cutting across. So now the back of the spine is here, the front is over here, and that bone spur is projecting forward. Here's the spinal cord, here's the bag of fluid, and you see this nice little sharp calcified thing pushing through, contacting the cord with this little blush of white stuff here, which, by the way, was not called a spinal fluid leak by our radiologists. We patched him at this location. He got all better. This is a patient, or an image from a patient. Again, a myelogram. Here's the spinal cord. Here's the bag of fluid. And you see this little bone spur here poking into the back, and this little blush here, kind of faint. This patient had been noted to be having headaches and dizziness. She had a brain MRI that showed her cerebellar tonsils were low, but instead of interpreting that as a CSF leak, they interpreted it as Chiari. So they did surgery on her skull base and opened up her skull, which did nothing. Well, it didn't fix her symptoms in any case. She was also noted to have neurogenic syncope. And when she presented with this constellation of neurogenic syncope and Chiari, we thought maybe actually the underlying problem is a leak, which led us to do this myelogram and find this finding, and we wound up patching her. I'll show you pictures of her. Now the question is, can you identify an important bone spur on MRI? Because I've just showed you CT myelograms, and as we were discussing amongst ourselves and the group of doctors this morning, many people are reluctant to do a CT myelogram. You've got to stick a needle in someone's spinal fluid, which is going to cause a little leak, it involves radiation. No one's happy to be irradiating otherwise healthy people. But can you identify this kind of thing on an MRI? Here's a case of someone who developed terrible refractory headaches, dizziness, nausea. She had this pervasive, awful smell continually in her nose. No one really understood what it was. And then she's walking in Disney World one day and has a full-on grand mal seizure. I first saw her when she was coming to the pain clinic to get occipital nerve blocks, ostensibly for occipital neuralgia, a kind of nerve pain problem in the back of the head. And I was bothered by the fact that she'd had this grand mal seizure, because it's hard for me to put together grand mal seizure and occipital neuralgia, but it's easy for me to put together seizure with CSF leak. So we went ahead and did an MRI. This is what it looks like. This is the front. This is the back. The dark stripe here is her spinal cord. The white stuff is spinal fluid. And this little disc bulge. Doesn't really look like that much. Here it is, blown up bigger. This is what it looks like on the axial image, where, again, the back is back here, the front is here. This looks a little unusual in the sense that the disc bulge is kind of focal. It's not broad-based, but you can't tell anything about it that makes you think it might have a sharp edge. And this is what it looks like on a CT myelogram, all right? So here's your spinal cord, here's the bag of fluid around it, and here's this nice sharp-edged, calcified osteophyte that came out of that disc, poking all the way into the front surface of the cord here. And you can see at the level below and at the level above the contrast out along the nerve root like in our previous gentleman. And that turned out to be a spinal fluid leak. So now, if you convince your doctor to go forward with looking for a spinal fluid leak, there's still more things for them to get tripped up on. One of them is something called an opening pressure. An opening pressure is when we stick a needle in the back like this into the spinal fluid and you connect it to tubing, and you see how high up the tubing the water goes. The more pressure in the spinal fluid, the higher the column of tubing, or the higher the column of fluid will rise in the tubing. Now, the problem is, we think we know that normal opening pressure is between 65 and 195 millimeters of water, which means that the column of fluid will climb somewhere between 6.5 and 19 centimeters of water. It is very hard to have an opening pressure of less than 6 without having a leak. However, that does not address what's the likelihood of a leak if your pressure is 10 or 12 or 15. And in fact, that has been looked at by another group of expert CSF researchers at Duke, which I've mentioned the group at Cedars-Sinai. I should give a shout out to Linda Gray and Peter Krantz. Peter Krantz was the first author on this. And Duke is one of the main centers treating people with spinal fluid leaks. And this is a quote from their paper, looking at 99 subjects with confirmed image-positive CSF leaks. There is no difference in CSF pressure for patients with leak versus without a leak on their myelogram. And this is the pressure of the people with leaks and the pressure of people, this is no leaks and this is with leaks. And the average pressure was above 8, which is well within the supposed normal range, above 6, okay? Similarly, another study, here's their citation, 5 of 17 patients with documented CSF leak had normal opening pressure in that study. So a normal opening pressure does not rule out a spinal fluid leak. And so if your doctor's saying we don't need to look at this any further because your opening pressure is normal, here's a study, and here's a study that you can bring to your doctor and say, hey, look, maybe we need to look at this more. All right, what about labs? In one series of patients with spinal fluid leak, 7 of 12 were found to have elevated CSF protein. And this, even though it's a small study, actually seems to be about the ratio of people that we look at who have elevated spinal fluid protein. So the thought is that if you reduce the pressure inside the skull, that the veins expand, and as the fluid pressure decreases, the difference between the venous pressure and the fluid pressure increases, and so you start to get plasma infiltrating across the veins into the spinal fluid, carrying protein with it, and you get elevations in protein. And maybe about half the people we see with good stories for leaks wind up having an elevated CSF protein consistent with a spinal fluid leak, and that helps tell us that we're on the right track. You see someone with an orthostatic headache and elevated CSF protein, there's a good chance that you're on the right track. Another study found that the average CSF protein in a series of 56 patients with a CSF leak was elevated. The citations for that are there. Again, that gives you reason to measure, to put a needle in the back, and I would argue for doing a CT myelogram where you can get the opening pressure, measure the CSF total protein, and get the kind of imaging to look and see if there's an osteophyte pushing on the dura somewhere. We're just about out of time. I'm going to let you know that you can also have an elevated prolactin when you have a spinal fluid leak. The thought is that traction on the brain causes some traction on the stalk between the hypothalamus and the pituitary, causing the pituitary to make more prolactin. And so The last thing I'm going to show you is some of the limitations on our neuroimaging tests, because the best study looking at neuroimaging for CSF leaks looked at 100 patients prospectively gathered from 11 hospitals in Japan. Of these 100 patients, 89 had brain MRIs. Of those 89 brain MRIs, 1/5 or 20 of the 89 were found to be positive. What we don't know is how many of these 69 are false negative. Why? Because in order to know that, we need some kind of gold standard to compare them to. And there is no gold standard. There's only correlation with other imaging studies that we don't know how many false negatives those have. What you really want to do is take that bag of fluid out of somebody, look at it up and down, turn it around, and see if you can find a leak, but you can't do that. And so the truth is in this study, they didn't report how many of these were false negatives because they don't know. There were also 89 radionuclide cisternograms, 70 axial spine MRIs, and 86 MR myelograms done on these same patients. Of the 86 MR myelograms, which is supposed to be the best MRI test for looking, only 3 leaks were found, even though we know 20 of these people had imaging positive leaks based on their brain MRI. MR myelogram only found 3 of them. Axial T2 spinal MRI did a little better, finding 14. We don't know how many of the radionuclide cisternogram because they didn't report that. Overall, spinal imaging was only able to detect 16. And of those 16, only 13 of the 20 positive brain MRIs were explained. In other words, 7 of the 20 MRI-proven spontaneous intracranial hypotensions were missed on multiple spine imaging. So we have reason to think this test is not perfect, and we have reason to think this test is not perfect. This study gets quoted all the time, and it talks about MRI compared to CT myelogram for looking at orthostatic headache and CSF leak. All right, so this was published in 2013 in the journal Neurology, a really prestigious journal, and they talk about spinal MRI having a sensitivity of 91.7%. But what did they do? They looked at 12 patients who had CSF leaks found on CT myelogram, 12 patients with CSF leaks documented on CT myelogram, did MRIs on them and found that 11 had leaks that they could see on MRI. And then based on that, they said it's 91% sensitive, which is supposed to mean 91% of all leaks are found with MRI. But in fact, what they've only shown is that there's good correlation between MRI and CT. They should be reporting an interclass correlation coefficient, not sensitivity. All right? And yet, this gets repeated in review articles as evidence that MRI is a good test for ruling out a CSF leak when we just don't have evidence of that. All right. There are some new imaging findings that may be more promising. This is the citation for it, looking at mammalopontine distance, or looking at this angle here in the brainstem called the pontomesencephalic angle. So if you want to let me know that you're interested in either research or treatment related to CSF leaks, this is the QR code. It will take you to a questionnaire where you can leave information so that I can get in touch with you. The password is CSF leak. That's the bibliography for what you heard here today. This was our first POTS patient that got sent from the POTS clinic. Her name is Kristen. This is what she could do with her hands. This is what her MRI of her brain looked like. It shows no evidence of a CSF leak. She was disabled at the time that I saw her on disability. Her CT myelogram showed this one little weird contrast along the nerve root here where there's this little osteophyte adjacent to the nerve root. And this is what she looked like after 2 patches to fix her. That was almost 3 years ago now. I get Christmas cards from her riding her motorcycle. This is the gentleman with the bone spur in his neck. You remember the contrast out along the nerve root. Here's his MRI that shows no evidence of a CSF leak. And this is him after being patched. He also went back to work as a game warden in South Africa. This is our patient with the neurocardiogenic syncope with the little contrast streaming out here from the bone spur. This is her MRI showing no evidence of a CSF leak except that Her tonsils, cerebellar tonsils, go below where the bottom of her skull was resected for her Chiari surgery. And this is her after getting that bone spur patched. All right, we've seen CSF leaks diagnosed as chronic migraine, chronic daily headache, new daily persistent headache. We've seen it misdiagnosed as Chiari. We've seen it misdiagnosed as POTS. We've seen it misdiagnosed as chronic fatigue syndrome, traumatic brain injury, post-concussion syndrome. And except POTS, none of these should get better with prolonged flatness, okay? That's my son. Someday he's going to watch this talk on YouTube and wonder why his dad was here. And I wanted to put this up just to let him know that I love him. And this is my daughter when she had her spinal fluid leak in the hospital, when we didn't know what was going on, and we kept winding up in the hospital, and my relatives were telling me that maybe I actually needed to quit my job to take care of her. And so I've been to that dark place that I know a lot of you in the audience have been to. As James Taylor talks about in his song, Lord knows when the cold wind blows, it'll turn your head around. And I know that feeling, and I think those of you in the audience know that feeling too. This is her now. She did wind up requiring 3 blood patches, and that's been really a miracle in our life, which is why I'm doing this. And so I ask of you guys, if you know someone whose story matches the symptoms that I talked about, spread the word. If you don't know someone but you want to be supportive, reach out to the Dysautonomia International and be supportive with your pocketbooks, right? You know, things like this conference don't happen for free. If you want to be part of the solution, do something concrete. So this is me calling you to service, to be part of the solution for this problem and to help people. Thank you very much.